Good afternoon and welcome to the Maine Health Management Coalition's webinar on provider satisfaction, the key to achieving the quadruple aim. My name is Marie Stuckey. I'm the Member Relations Manager here, and I will be going over a brief introduction about the coalition for people who are tuned in that are not familiar with our work, and also to keep our members up to speed on current events. I'd like to thank our presenters today, and we'll be introducing them shortly. I also want to let you know that we will be taking some questions, fielding them at the end of the presentation and reading them to our presenters. So if you have questions as you're listening, just type them in the chat box at the bottom of your screen there, and we'll collect them and ask them at the end. The webinar is also being recorded and will be available on our website, our member website, at the end of the day, most likely. So just to begin with a little bit of information about the coalition, we are a purchaser-led coalition, but we are made up of 5 main groups, including consumer organizations, purchasers or plan sponsors, health plans, brokers, benefit consultants, providers, and affiliate organizations. And we work together to improve health and maximize the value of healthcare services in the state for all the residents and for our members and their families. Our vision is basically to lead the country in population health status, patient care experience, and have reasonably priced per capita healthcare expenditures, so we have a favorable business climate and good job growth and development. So how do we achieve this? We have 5 main initiatives that we use to achieve this. The data department here is the foundation for all this improvement. We have the state's all-payer claims database, where we can do benchmarking reports and analysis of plans to help our members understand where they could improve their benefit plans. We also have a public consumer website called Get Better Maine, where we report on the outcomes, safety, patient experience, and cost ratings for adult care, pediatrics, and a bunch of specialties, which is helpful for transparency of services, quality, and cost. For consumer engagement, we've done many different things such as book clubs and wellness competitions, and try to support our members with resources that they can share with their employees for their own wellness and accountability for their own wellness. We also have a department that works on value-based insurance design, a new plan that rewards the use of high-quality, patient-centered, evidence-based care, and that's in development with all the major health plans in the state. Finally, we work on payment reform. New arrangements with providers, hospitals, and systems are in discussion in some patient-centered care at a reasonable cost. The benefits of membership at the Maine Health Management Coalition are many, but I'll just list off a few things. Basically, by convening all these work groups together, we're able to provide a network where our members can learn from each other and make valuable connections. They can identify the best practices in health plan design and workplace wellness. Again, they can have access to our great data analytics team and trained staff and leadership through educational events and resources. And webinars such as these are free to our members as well. Our members also have voting rights in influential elections. Some of the work that we do is done through several work groups and committees, and this year we're also working to develop learning collaboratives. I mentioned already the voting rights. We'll also be developing some provider and employer roundtables. We do hold an annual large symposium. It just passed. It was in November. It was record-breaking. We had a wonderful turnout. Our members also get a newsletter with all the current news of healthcare reform in the state. And this is just a logo showing you, a slide showing you the logos of several of our members. So without further ado, I will present our presenters for today. So Ellie Rakovich is a practice development advisor on the American Medical Association's strategy team dedicated to professional satisfaction and practice sustainability. Prior to joining the American Medical Association, as a practice manager for Northwestern Medical Group, she managed 5 multi-specialty medical practices in the Chicago area. Previously, Ellie oversaw New York University's Langone Medical Center's Service Excellence Department and worked throughout the organization as a patient experience coach. Ellie has her Lean Six Sigma Green Belt from the University of Michigan College of Engineering. She earned her BA in the History of Science and Medicine from Yale University and her Master of Public Administration in Health Policy and Management from the New York University Wagner School of Public Service. And she is joined today by Michael Tuddy, PhD, Master of Health Administration, and he is the Group Vice President of Professional Satisfaction and Practice Sustainability at the American Medical Association. Michael manages AMA's efforts to identify, support, and grow the models of care delivery and payment that promote the long-term sustainability of and satisfaction with medical practice. Prior to joining the AMA, Michael served as the Director of the Office of Health Policy and Technology at the University of Massachusetts Medical School. Previously, he worked at the Boston Consulting Group in their healthcare practice. Michael maintains an assistant professor faculty appointment in the Department of Family Medicine and Community Health at UMMS and is an adjunct professor at Clark University. He earned his BA in government from Western New England College, his Master's of Health Administration from Clark University, and his PhD in Public Policy from the University of Massachusetts, Boston. So with that, I will now pass the controls over to Michael and Ellie and thank them again so much for sharing their expertise today.
Good afternoon. This is Michael Tuddy. I'm glad to be participating with Ellie this afternoon. We are sitting here in Chicago, a rainy, drizzly, but warmer than usual Chicago. So we're much appreciative that we're getting some warmer weather. And I think that's going across the country, so hopefully you're getting that in Maine as well. It's an exciting time at the AMA as we're going through a number of strategic transitions of our organization over the last number of years, starting in 2011, where we were changing our sort of focus and really trying to get more impact as an organization. Today, what we're going to cover is give a quick update of our presentation. We're going to talk about why provider satisfaction matters and what we're doing about it at the AMA, and we're actually going to be providing some tips that Ellie will go through and some resources about how practices can think about improving provider satisfaction within their own institutions. And this provider satisfaction, a lot of the issues are similar for all the staffs within the organization. And then we'll go through some of what these modules are and talk about our steps forward practice transformation platform and how you can take advantage of some of these resources, which are free. We're really trying to help practices sort of improve the working environment for the healthcare providers. So just a little bit more background about the AMA. 2011, we went through a strategic planning process to figure out how as an organization we could have more impact. The AMA has been around since 1847, so we're 168 years old this year. And when we did the strategic assessment, we found, like many organizations, we had many, many priorities, something over 100 that we were claiming were strategic priorities. But with any organization, if you're focusing on 100 things, you're really not focusing on anything at all. So we decided over the next decade, we would focus the AMA on 3 priority areas so we can have more impact as an organization and do more to try to improve healthcare. One is improving health outcomes, and our team is specifically working around prediabetes and hypertension. We've signed up interesting partnerships with some groups like YMCA to the American Heart Association for people to really start to take advantage and help providers manage these chronic conditions that are widespread across the country. A second large initiative that we've taken on is improving medical education. The AMA was actually involved in the early 1900s with sort of setting the standards for medical education that we still train medical students today, 100 years later, almost the same way, with 2 years of basic sciences and 2 years of clinical care. While the curriculum has been updated, we continue to try to cram more and more in that same sort of framework. And we set out by offering grants to medical schools, and we ended up getting over 85% of medical schools to apply. And we created a consortium initially of 11 medical schools that we awarded $1 million grants to, but we expanded that with another 21 schools this past fall, where we now have 32 medical schools collaborating to start to change how medical students learn, thinking about a more dynamic approach, understanding the capabilities and differences that medical students have, and the dynamic nature and changes that education are needed to educate physicians for tomorrow's healthcare environment. The last area that Ellie and I are involved in, and the area we'll discuss today, is our work around improving professional satisfaction and practice sustainability. When we kicked off this initiative in 2011, 2012, we were hearing more and more stories about physicians who would not recommend the profession to their children, talking about a work environment that was becoming more and more difficult to work in, with the additional regulatory requirements, the transition to electronic health records, which was requiring more documentation and time doing documentation by the physician, and an ever-changing reimbursement environment, which is creating different financial incentives for not only physicians, but the whole healthcare team to work differently. So we kicked off this initiative to really understand why were physicians dissatisfied. And we did a study with RAND Health in 2012, 2013, and we released it in 2013, called Factors Affecting Physician Professional Satisfaction and Implications for Patient Care, Health Systems, and Health Policy, to try to identify what are those activities that are really taking away from the satisfaction of the physician and healthcare workforce more broadly. And great takeaway from this entire report, which is publicly available on the RAND website, as well as the AMA website, is that physicians are satisfied when they feel like they can provide high quality care to their patients. They're dissatisfied when they feel like there was barriers to providing high quality care. Many of those regulatory, electronic health record, insurance, prior authorization, those barriers to providing care were all the things that took away from professional satisfaction. We really heard a lot, by the way, and I'm sure many provider organizations are aware, around this transition to electronic health records and the required time it takes for physicians and care teams to do this added documentation, many of it around regulatory requirements. And physicians also worrying about the sustainability of their businesses and practices as a business model. And we're seeing that nationally as more and more physician practices are being bought up by larger health systems. What is the future sort of model and role and opportunities for engagement with physicians? And finally, one of the big areas were sort of regulatory burdens, with many things adding up. But the one that we heard most frequently due to the timing of the study in 2013 is the requirements around meaningful use. The report ends saying that there are things that physicians can do to improve their work environment, and there's also larger external health policy issues that groups like the AMA should work on. Those larger external issues are issues around EHR technology, and the AMA has been aggressively working with the EHR vendors, and just this past week had a meeting with the EHRA, the vendor association, meeting with all the vendors in Chicago, talking about how we can collaborate more to improve the usability of their products. We continue to regulate, push the regulators to eliminate and reduce some of the administrative burdens. We're actively engaged in how the Stage 3 meaningful use will get implemented, as well as how macro will get implemented, the SGR replacement bill, or the bill on how physicians' reimbursement for Medicare and providers' reimbursement for Medicare will change. We're also actively involved in some larger sort of payment changes in these move to alternative payment models. While we're working on those larger sort of national issues, we do believe that physicians can take more control of their own environments and do things, and providers and the healthcare teams, to create an environment that is more conducive to high quality patient care and a more satisfying team-based work environment. From our research, we did find practices across the country where the care teams were much more satisfied. So we went out to try to find out what are those practices doing differently where they seem to have a highly functioned, highly satisfied workforce. From that, we've identified those changes, and we're figuring out how to make other physician practices understand what those are and how they can implement those in their own practices. And so that was part of our practice transformation effort called Steps Forward. As you can see on this slide, just some of the work buckets that we're working on across the AMA in these areas, again, around physician payment, how physicians organize in the future of EHRs and digital health, as well as physician leadership training. But today we want to spend our time, and Ellie will go through our Steps Forward platform and some of the resources that we've identified as sort of best practices on how you organize and function an ambulatory practice, and how we're offering some of these tools that practices can implement within their own organizations. So I will turn it over to Ellie so she can talk about some of the concrete steps that practices, physicians, and their staffs can take to improve their environment.
All right, thank you, Michael. All right, yeah, so we're excited to share some of these really practical tools and tips and information with you that have made a difference in other practices that can more than likely be easily transferred to yours. So at the same time that the AMA was doing the RAND Health study looking at sort of the dissatisfaction for physicians and medical practices, there was another study going on that was done by a physician named Christine Sinsky, who has since come on our team as a vice president in our group. And they looked at the characteristics of what made medical practices work and gel and increase satisfaction for not just physicians, but for the whole team. And what they found was that these practices had embraced a team approach to care. You'll hear people talk about the hero model, where the physician is kind of doing everything and then the other people on the team are working more for the physician, not necessarily with the physician. And these practices had really embraced having everyone on the team play a really integral role, not only with the physician, but with the patient. And so these teams had really important relationships with patients, so medical assistants and nurses knew all of the patients personally and were able to take better care of them, and all of the work wasn't necessarily falling directly to the physician. Another thing that they've done is, as all of these administrative and regulatory changes had been coming, kind of down the pipeline, and all of these different requirements started coming out, they stepped back and redesigned the way the care was provided in their practices, as opposed to just adding more and more and more. When I was working in operations, we used to always say that we were expected to do more with less. You aren't getting more staff, you aren't getting more resources, but you still have to do more. And so these practices took a step back and redesigned the way they took care of their patients. Another important characteristic of these practices is that they really emphasize planning ahead for the patient visit. So every patient that came in, everybody on the team knew what they were coming in for, and they were able to have efficient, effective visits, as opposed to, kind of working haphazardly throughout the day and creating a chaotic environment, which impacts physician satisfaction, team satisfaction, and burnout for everyone involved. The practices also have very strong communication, not just among members of the care team, but with patients as well. And the physicians felt that they had a strong working relationship with their administrators and had like priorities, and they felt like they were working toward the same common goals. So some of the, like I said, practical tactics and tools that we're going to go over today that are really the base of team-based care, or the foundation of team-based care, are prescription management, pre-visit planning, expanded rooming and discharge, team documentation, and then huddles and team meetings. So some of these are related to direct patient care, and then some of them are related to increasing communication and building a team culture in your practice. The idea with synchronized prescription renewal is that when a patient comes in for a visit, the physician and team can work together to prescribe the patient's prescriptions for the entire year. For some of your patients who have a handful of different medications that they're on, and maybe they're prescribed for 2 months or for 3 months or for 4 months or 6 months, they're calling your practice a pretty solid number of times over the course of the year to get those medications refilled. While this isn't a huge burden on physician time, it really is for your nurses, your medical assistants, and whoever, and the patients who have to hunt down those medications before they go on vacation. We've all dealt with the frantic phone calls about, I thought I had a week left, but today's my last day and I need this, and everybody's jumping through hoops to try to get the prescription refilled. A more systematic approach to prescribing medications for the entire year can decrease a huge number of those phone calls, and some practices who use this tactic will say that they save an hour of nursing time a day, and their patient medication adherence increases because patients don't have gaps in taking their medications. This is one improvement that you can make in your practice that is free to implement. It's simply changing your approach to something that is done in the practice every single day. The next tactic that we'll talk about is pre-visit planning. And there are a handful of different components of pre-visit planning, some of which you're probably doing in your practice now. I think, everyone on your team is probably thinking about what they can do to prepare for a patient visit, and the people in your practice know which patients need which things when they come in for their appointments, and pre-visit planning adds some really great structure around it, and hopefully you'll hear some things today that can help you streamline your approach. The first approach is called pre-visit lab testing, and this is one of my favorite tactics that we have, and one that I wish we used in my practices when I was working in operations. It's a huge time saver, and it can make a huge difference in the patient care that you provide. The idea is that instead of having patients come in for their appointment, and at the appointment they have their labs ordered, and then they go have the test done, and then the care team is responsible for following up with the patient and giving them their lab results. Instead, the patient would have the labs done beforehand, and then instead of trying to hunt the patient down to give them abnormal results or talk about change in treatment or lifestyle to address the issue that's been identified, that conversation can happen in person at the visit. One practice that uses this tactic has found that in a 4-hour clinic, they were saving 2 hours of staff time in patient follow-ups. Their patient adherence was increasing, and they were having fewer cases of patients who were not being given the information that they needed in a timely manner. You're having less information falling through the cracks.
And Allie, one of the physicians I spoke with who implemented this sort of pre-visit lab in their practice talked to me about they're catching things in labs now that they weren't catching before, because when the labs are entering their inbox, and as most physicians are trying to clean out their inbox, you're going through all the things in your inbox very quickly. And you quickly look at results and you send the letter off to their home that they're fine, or if they're high, it's, they're maybe in that borderline where you have to have that conversation, which would be great to have if they're in front of you, but if the patient's already gone home and you have the results a few days later, they have found that when they're actually pulling the results up and having that time in front of the patient to discuss it with them, and they actually have that conversation with the patient, it's more engaging. They're catching little things that may be borderline that they would have just given a quick glance at when they're going through the inbox. So it works quite well. It's something actually I just had my physical. My physician used it. I went in a week before to get my lab work. When I had my physical, we went through all my results and we were able to talk about them, as opposed to getting a letter a week later that says, "Oh, Michael, your labs look fine." So it is a great technique both to eliminate some of that after the patient has gone administrative work that you're not getting paid for a week later to send that letter for to the patient. But doing it when the patient's there is much more effective.
Yes, thank you, Michael. The physicians who use this absolutely love it. And obviously, you know, you're thinking through some of the operational challenges that you'll have in setting this up, but the payout is just huge. We have a case study that was done at Massachusetts General Hospital in Boston, in your neck of the woods, and they found that after implementing pre-visit lab testing, they saw an 89% decrease in the number of phone calls that they were making about lab results after the fact, an 85% decrease in letters that they were sending out from the practice, an increase in patient satisfaction, and they quantified that they were able to save $24 per patient visit in staff time and administrative work that needed to be done. So this is, like I said, a huge win, and again, patients love it, and they are more engaged in their care, which is obviously a great thing. Another tool that you can use is a visit planner. And the idea with a visit planner is that care that the patient needs to receive at a certain appointment or as a follow-up to a certain appointment is all coordinated at the current appointment. Instead of having to call the patient and say, oh, you know, we were going to do some follow-up labs, or you were going to have an MRI done, or you needed to see the specialist. When the patient leaves the office, all of that follow-up care is taken care of. Most electronic health records have this capability built in where you can place future orders or referrals. That's great. The idea is that those are actually scheduled for the patient by the time they leave the office. It increases patient compliance and reduces the administrative burden of having to follow up with patients after the fact to make sure they are compliant, which again is one of those things that often falls through the cracks in the busyness of a clinic day. The next tool is a visit prep checklist, and I should mention that these different tools that we're talking about are available on the Steps Forward site. You can see in the bottom corner that it's called stepsforward.org, and the different topics that we're talking about today are actually individual modules where you can learn about the step-by-step, I guess, the steps.
Step-by-steps on how to implement it in your practice.
How to implement in your practice. Yeah, I was going to say the step-by-step steps, but that was clearly not going to get us anywhere fast. So the visit prep checklist is something that your team can do before the patient comes in. Like I said, with pre-visit planning, the goal is that patients are coming in, we know what they are here for, and their time with the team is going to be efficient and effective. The visit prep checklist can help you manage your patient's health and be prepared for each patient who comes in. So if a patient needs some sort of preventive test, diagnostic test, immunization, that can be caught in this checklist so that when the patient comes in that day, everyone knows what that patient needs and it can be taken care of for the patient that day. Finally, the pre-appointment questionnaire is a form that can be given to patients either when they come into the office for their appointment or before they come into the office for an appointment. It can be emailed to them. It can be made available through a patient portal. And it gives the patient the opportunity to fill out some of their information so that the team is able to, in a very timely manner, update the patient's chart. It gives the opportunity for the patient to indicate any updates to their history, any symptoms they're having, any behavioral items like smoking, exercise, alcohol consumption. It gives the patient the opportunity to indicate whether or not they have anything in particular that they want to cover during the visit that day, and they can write down what their medications are, making the medication reconciliation process easier as well. The form for your Medicare patients can mirror the annual wellness visit form, and it can be built, the form can be built so that it mirrors the input field in your electronic health record, so that your team isn't flipping back and forth between tabs or pages trying to make sure that all of the information is entered correctly, and it can make the process more seamless. Ultimately, we would envision that this would be done via patient portal or kiosk. Again, the electronic options are often great so that the patient can do it on their own time as opposed to taking up more time in the waiting room. But the questionnaire can really help focus the visit and get the whole team, which includes the patient, aligned on what they want to accomplish that day. The next tactic is expanded rooming and discharge protocols. The idea with expanded rooming and discharge protocols is that there's a lot of work that can be done during the patient visit that does not need to be done by the physician. And it will give you the tools to use your medical assistants, your nurses, and other members of the team. Some people use, health coaches, people with physical trainer backgrounds to do some of this non-physician patient work. And obviously what those people can do is going to be dependent on your state laws and what the what the level of training is that those people have. But we've seen a ton of different models that have all worked well, and the idea is that the burden is being shared with other people on the team, not just the physician. And this is another way for your team to develop really strong relationships with your patients, because your team members aren't just doing height, weight, blood pressure, and then letting the physician take care of everything. They're really involved in the patient's care, and they're able to develop relationships with your patients. So on this slide, we have some different items that the members of the team can do to during the rooming process. They can obviously do vitals, something that's very commonplace. They can do a medication reconciliation, use standing orders to take care of certain care that the patient might need, like immunizations, ordering preventive testing. If you have nurses and your physicians feel comfortable, they could do a diabetic foot exam. We've seen that in certain practices. Again, that's going to be potentially a scope concern for some of you, but the idea here is that we're kind of thinking outside the box in terms of what other people on your team can do to ease the burden on physicians. They can do the data inputting into the medical record for the annual wellness visit, do an initial review of lab results. If you implement the pre-visit lab protocol, your lab results are going to be available in the medical record, which is great. If you have your medical assistants or your nurses do normal lab resulting to your patients, now they can absolutely indicate in the room that the patient's lab results all look good, and the physician will be able to discuss in more detail. Obviously, if the patient has abnormal results and those team members are not currently doing abnormal resulting, and that should be a physician conversation, then the medical assistant or nurse would know, and they would be able to say that the physician will be discussing the lab results with them, or not say anything at all and save that for the physician portion. But during a handoff to the physician, they can say, I noticed that the patient's X lab results seemed out of normal range, and that's, flag that for the physician to discuss with the patient. And then finally, as the patient would have indicated on their pre-visit planning form, the nurse or medical assistant, whoever is rooming the patient, would have the opportunity to focus the patient in terms of what they wanted to cover during their time with the physician. At the end of rooming, that person can then do a quick handoff with the physician. Sometimes this happens in the hallway, sometimes it happens in the patient room. Often it's easier to have the other person step out and find the physician and do the handoff and transition care. But that communication from the person who has roomed the patient to the physician is really important, because you're essentially transitioning care. If the patient has to, say all of these things that they've already indicated to one member of the team, again to the physician, it's not accomplishing everything that it can. And so that huddle to transition care is really important. During discharge, with the expanded rooming and discharge protocols, the discharge portion is also really important. So the physician can leave the room, and then the nurse or medical assistant or health coach or health educator can come in and reinforce everything that the physician has said, potentially do some coaching and some education with the patient, and make sure that they understand everything that they need to before they go on their way. The next tactic is team documentation. This is often referred to as scribing. We prefer to call it team documentation because the implication with scribing is that you have people who are non-clinical who are scribing a visit. But we've seen some models that are really valuable where people with clinical backgrounds document the visit, and that's a really effective approach to care.
Yeah, so scribes are actually a good tool, and for some specialties, like emergency room physicians, they have found that hiring scribes can be a good resource, and those costs are augmented by the productivity of the care team. But in other specialties, particularly primary care, may not be worth hiring a direct person with a scribe title, but by bringing the documentation and having it spread through the whole team and sort of sharing that responsibility, which is why we promote not just the scribe model, but also team-based documentation. So it's not necessarily hiring a new resource.
Yes, thanks, Michael. So the idea with team documentation and the team care model is that somebody accompanies the physician into the room. It could be the nurse or medical assistant who just rooms the patient. They can do a quick handoff to the physician, and then they can both go in together. And the physician can do their portion of the visit, and the other person can be documenting the visit, placing orders, updating medications, ordering medications, and then they can stay in and take care of the discharge responsibilities. Or in a more traditional scribing model where you have someone without clinical training, they can shadow the physician in and document the visit for the physician, and then potentially take care of some care coordination activities like scheduling follow-up appointments and that sort of thing after the visit. So we have a couple of examples of different practices that have used this model and have some results to share with you. So at the Cleveland Clinic, there's a physician there named Kevin Hopkins, and he made a business case to work with 2 medical assistants instead of 1 medical assistant. And he found early in his career that he was not having the experience that he wanted to in his professional life. And he was spending a lot of time, with the computer, and he felt not enough time with patients. So he made a business case. He said that if he could increase his patient load by 2 patients per day, he'd be able to cover the cost of the additional medical assistant. When he implemented his team care model, he was able to increase the number of patients that he saw per day from 21 to 28, and his practice saw a 20 to 30% increase in revenue, and he actually started having fun with his medical practice for the first time. At Bellin Health System, which is in Wisconsin, northern Wisconsin, Green Bay to be exact, they started doing a team care pilot where they used 2 medical assistants for each MD, and they found that this was hugely successful. They were seeing a significant return on their investment, and they are looking at spreading across their entire medical group in 2016 and 2017. A study was done at UCLA Geriatrics and Internal Medicine, where they used 3 physician partners for every 2 physicians that they had. And these physician partners were most often young people who had just finished their undergrad in some sort of pre-health field, and were looking to get some practical frontlines experience. They found that in a 4-hour clinic session, they were able to save 28.2 minutes in geriatrics and 40 minutes in internal medicine by having these physician partners shadow the physicians into the room and take care of some of the care coordination, like patient scheduling and patient wayfinding after the fact. So the physician was able to be done with the visit and move on to the next patient. And they saw impressive results with their patient satisfaction as well. Amy Halpert is a family physician who said, "I get to look at my patients and talk with them again. We're reconnecting. Our patient satisfaction numbers are up, our quality metrics have improved, our nurses are contributing more, and I'm going home an hour earlier to be with my family." So a total win.
Sounds like a great outcome there.
Yes, absolutely. Huddles and team meetings are 2 things that you can do to increase the communication among your care team. A huddle is a quick check-in before the clinic day starts, just to get everyone on the same page and align in terms of any staffing issues, staffing changes, and patient issues that everybody on the team should be aware of. Maybe a patient has gone through a hard time and needs to have a behavioral health consult that the team wants to flag, or a patient who was recently seen in the emergency department needs to have stitches taken out. The suture removal kit can be ready for the patient when they come in, so that the person who's rooming the patient doesn't have to leave, go get the suture removal kit, and come back. It's those sorts of disruptions during the day that can really take up a significant amount of time when you add it all together. Team meetings are another opportunity to really build a strong culture and provide an opportunity for people on the team to work together toward a common goal, which, you know, happens not enough often when people are in their day-to-day. The idea with these is that the team has the opportunity to sit down and align and connect. At a meeting last week at a health system, actually in Wisconsin, we were talking about some high-performing teams, and it was very interesting that 2 of the practices that were mentioned as high performers, when asked why these practices were high performers, they answered that it was because they had regular team meetings. All right, so what can you do? I think the first step is to assess your staffing. What can you do with your current resources? Some of the stuff that we talked about is going to be easily implemented without increasing resources. Some of them, like team documentation and even, you know, doing more coaching at the back end of a visit, could be challenging with your current staffing model. So look at what your staffing is and what your capacity is to take on now. Oftentimes when you're changing your staff roles, you're going to have to train them. And so we have some training resources on Steps Forward, and also some information about what implementation entails, which is going to help you identify exactly what your gaps are and start working on filling them. For physicians, it's going to be important to partner with administrative leaders to address some of the policies, procedures, rewriting job descriptions, identifying training opportunities, that sort of thing. If you're changing a staff member's role, a lot of times it's challenging to pay someone more, but you're giving them a different role. And so what we suggest is that you consider changing someone's job title so that it really reflects the fact that their role is different. Even if they're not a medical assistant anymore because of your traditional medical assistant role, clinical partner is a term that we've heard other practices use that really highlights the fact that the person is partnering with the patient, partnering with the physician, and they're not just a medical assistant or a certified medical assistant anymore. We do recommend starting with pilots, finding a physician or a team or a pod that's interested in implementing one of these ideas, and then trying it out, seeing how it works, adjusting, improving, and trying to optimize before trying to spread across an entire clinic or an entire group. And obviously communication during any sort of implementation phase is really important. In partnering with your physicians, it's important to understand what is important to them and what they value. If they really value patient care, speak to that. If they really value getting home at a certain time, so they want to decrease the amount of work that they have to do after clinic, speak to that. If they, have other priorities or other thoughts, connect with them in a way that's not necessarily speaking administrator or operations speak, but physician speak, so that you can align with them and partner with them and start to implement really important changes. Being present is also really important in implementing any sort of change. There are two different tactics that you can use, shadowing and rounding. Shadowing is something that you can do with your patients, with your staff, with your physicians, where you're basically going through a patient visit or a day or a half day with a member of your team to understand what their day-to-day is like. And that can be a really enlightening experience for you, and it also shows your team that you're there, you support them, and you want to understand. Rounding is a tactic that you can use where you're basically going around to different members of your team and your patients and checking in with them. How are they doing? What's going well? What could be improved upon? And these sorts of conversations can be really valuable. And then finally, choose a starting point. Oftentimes, when we think about making changes or implementing something, it sounds really big. But starting with a pilot and starting with people who are on board and want to be a part of the change that you're looking to implement can be invaluable. As you go, you should anticipate that there will be challenges and setbacks, and that's okay. A lot of these practices that we've seen that have implemented some really impressive solutions to the problems that they were facing have gone through very challenging times, but they've stuck with it, they've adapted, they've been flexible, and they've all stuck together, which is really important. And then finally, celebrate each win. Even the small ones, when you get your first patient compliment about something that you're trying out, celebrate that and enjoy that moment so that your momentum can keep going. And finally, in summary, we want to just remind you that, some of the most successful practices that we've seen are really exceptional at teamwork, planning ahead, and communicating frequently with each other and their patients. And they have fun with each other. And we think that everybody can see these effects as a result of their work.
So, the AMA and I think healthcare more generally believes in the triple aim. We've heard so much about it, enhancing patient experience, improving population health, and reducing costs. It's been sort of widely accepted as our compass that we need to be working at to improve and optimize today's healthcare system. But we believe, and I think many do, we need to be thinking about the quadruple aim and adding that goal of improving the work life of healthcare providers, clinicians, and the staff, and the entire care team who's caring for patients. So we think that some of these resources that Ellie highlighted are great ways to start improving the quadruple aim. And again, just in conclusion, we'll take some questions if there are any. All this information is available on stepsforward.org. Every one of these topics are individual education modules with step-by-step instructions. If you click on, there's a tab that'll have downloadable resources, many of them Microsoft Word, so you can customize them for your own unique practice. Many of the modules also have videos that show you how to do it, or faculty talking about how to implement these activities within their practices. And finally, for those physicians who may be going through that, we do offer CME for going through the modules, and in 2016 we'll be offering MOC Part 4, the quality improvement portion of physicians' maintenance certification needs. So again, all those resources are for free. We want to get them out widely as used as possible because we're very supportive of the idea of improving the satisfaction of the healthcare workforce. So we'll stop there. We'll take any additional questions if there are any. Appreciate everyone listening to learn more about our Steps Forward program.
Thank you so much, Michael and Ellie. Really appreciate you sharing some great information with everybody that's tuned in today. I will remind everybody, if they have any questions, they can go ahead and type them into the chat box now. We do have some that I'll start with, but if you haven't added a question yet, feel free to do so at any time. And also want to remind everybody that they can access this presentation and the slides on the Maine Health Management Coalition member website. I'll send you a link for that once it's up. So the first question is, if my practice is interested in implementing some of these ideas, where do we start?
Great question. The first place to start is going to the Steps Forward website and seeing the different types of topics. You might be a little overwhelmed because there's probably 25, 26 modules that we have up on the website today, and you might say, well, where do we get started? I think getting a small work group within the practice to go through those and think about picking one topic, and just pick one topic that you might think that you can have some early successes on, and one that may not be as big of impact, but if you know you can have success, because success breeds success, and people will want to implement those ideas. But again, on the website there are what we're calling modules. Each one of these ideas is a nugget or a module with step-by-step instructions on how to implement those within your practice, with a number of downloadable tools and resources to facilitate that implementation. Ellie, I don't know if you have anything to add.
No, I think Michael's right on the money. You know, take a look with a work group in your practice. See what's going to be meaningful and impactful for you that seems feasible. Don't go for your big stretch, you know, blue sky project first. Start with something that seems manageable and doable, and get your team gelling together, and then start doing some of the stuff that's more challenging.
Yes. Some of this concepts that you might have heard of, Lean or Six Sigma, or some of the things that are the Toyota manufacturing. I mean, these are sort of the simple sort of step-by-step improvements that sometimes are missing in healthcare, and these are just highlighting some of those opportunities for improvement within the practice.
Yes.
Okay, that sounds like pretty practical advice. Also, another question, who can do pre-visit planning?
That's a great question. Pre-visit planning can be done by, you know, we've seen some different models in different practices. Sometimes it's the nurse or medical assistant who's going to be rooming that patient the next day. They take care of making sure that everything that they need for that patient is pulled together and ready. We've seen some patient care coordinators in practices or receptionists who have some downtime during the day and can make some phone calls, follow up with patients, make sure they're having some of their pre-work done, and check in with patients beforehand. So it really depends, and a team approach can be very effective too. You know, a medical assistant or nurse might be able to do some chart review to make sure that everything is ready from a clinical perspective, and then you could have other people who are making phone calls from a call center or your reception staff to make sure that they understand, you know, that they are going to need to come in a little bit early to do their pre-appointment questionnaire, that sort of thing. So it can be a team approach, and it's going to be practice specific. So think creatively about what resources you have and who would be best suited to do that sort of work. Michael, do you have any?
No, it's good.
All right.
I'm getting a few questions here about the website that you're referring to. So it might be helpful for you to literally spell it out, or I can certainly email it on to our attendees later if you want to email it to me. But can you repeat the name of it at a minimum?
Yes, and the URLs can be so tough. It's stepsforward.org, stepsforward.org, all one word, steps with an S, stepsforward.org. And when you get to the website, you have a blue background, you'll see AMA, Steps Forward on the top. If you don't see that, you've arrived to the wrong page.
Yeah, and Marie, when you share the slides, it's in the bottom right corner of every slide, and then it's on that final slide as well.
Oh, that's great. Okay. That's good to know.
People can very easily access it. And we should also say that because this is part of the AMA's, strategic area, you don't have to be a member. It's not a member benefit. We really think it's important that all practices can access this information and, implement some of these tools that we think are so important.
I think we have time to squeeze in one last question, which is who should be involved in implementing practice transformation efforts?
So I would start by saying that there definitely needs to be a team involved. Having a physician and administrator partnership, kind of leading the charge with a team of people who are going to be involved in the change is really important. And then depending on your practices or organization setup, if you need an executive sponsor to sign off on funds, resources, if you're going to be changing your staffing model, that sort of thing, that executive level support is going to come in really handy. But I think, in terms of redesigning or designing a new process in your practice, having your people who are involved in that process is going to be really important. So involve your medical assistants, involve your nurses, your people who are doing check-in and check-out as appropriate. And the more they're involved, the more buy-in they'll have, and the more successful you'll be.
Yeah, and these are incremental steps. And when you set these teams up, they're going to find ideas that aren't even on the website that are creative. We were talking with a practice who was having troubles with sort of collections and checkout, and they found out there was an exit door that said exit at the end of the hallway, and people after they left the patient were going out the exit door and not going back around to reception. And that was the reason. They just one of the steps of let's just put a sign there, and instead of making a printed sign, a staff person created it themselves. They put it up there, and now people know to turn around and not go out that door, but go back up to check out, and they're having better checkout process, better collections, and that was just a team-based discussing and finding out the problems and discussing as a team, saying, well, why is this happening?
Right, and such a simple solution. Well, great. Thank you very, very much to both Michael and Ellie. Really appreciate your thoughtful insight and sharing your expertise. And thank you also to everybody who attended. Again, we will be sending a follow-up email to alert you when this is available on our member website. And you'll also receive a little survey asking for some feedback on today's webinar. We'd love to hear from you and see what you feel would be best for future webinars and your response to today's presentation as well. So have a great afternoon, everybody, and thank you again for joining us.